Hello, my name is Tom Gross. I'm a senior partner in the orthopedic group, Midlands Orthopedics in Columbia, South Carolina. My specialty training is in joint replacement, and I perform all types of joint replacement, including total hip replacement, hip resurfacing, total knee replacement, partial knee replacement, and then revision surgery to correct problems with those. But my primary passion is hip resurfacing. I've been doing that for nearly 25 years, and I'm now in a three-way tie as far as experience goes worldwide. Ronan Tracy in Birmingham is probably number one in pure numbers of cases done. And then there's Koen de Smet in Ghent, Belgium, and Jim Pritchett in Seattle, and myself, who are in a virtual three-way tie for the number two spot in experience for hip resurfacing.
Can you give us some advantages and disadvantages of hip resurfacing?
Yes, certainly. I would say that there are only advantages, but we'll talk about some of the perceived disadvantages as well. Hip resurfacing just gives you a more normal hip, and it's also a more durable hip. But I will go through 6 different points on comparing hip resurfacing and total hip replacement. It's not just about what implant lasts the longest. There's lots of factors. The first and most important factor is function. Hip resurfacing recreates a more natural hip joint. If you just look at it, it looks more natural than what a total hip replacement looks like. And I've explained in other videos why that translates into better function. There are a number of studies, so those are theoretical ideas, right? That it looks more normal and that it therefore functions more normal. But there's actually scientific studies that have looked at this. Total hip replacement surgeons often claim that you get the same function, or you can get the same function out of a total hip replacement. That's simply not true. Here's the data. Number one, there's a study done by Jim Pritchett in Seattle. He has 300 patients with resurfacing and a total hip on either side, and they have an average of 7 years follow-up. So these are well-healed hips that are out there in the community. And the same surgeon of the same skill level has done both operations. He has someone else ask them what side they like best. 86% of them said the resurfacing felt like a more normal hip. That's pretty convincing evidence right there. Number two, there's a surgeon named Robert Barrick in St. Louis who did a very interesting multi-center study. In his center where he did resurfacing and other centers where they did total hips on young patients. So they didn't take young resurfacing patients and compare them to old total hip replacement patients, because that wouldn't be fair. They age matched them, the activity matched them, activity pre-arthritis. And then they asked them in very sophisticated activity questionnaires after several years, after the hips were well healed. And it came out that resurfacing patients were able to perform at a much higher level. So the standard hip questionnaires we ask patients don't get at that. It's just if you can walk a mile with your artificial hip, you have an excellent outcome. But people want to do way more than that. People can walk faster, they can run, they can play more sports that they desire with a hip resurfacing. So that's the second major study that shows better function. The third group of studies was done by Justin Cobb in London, who is also a resurfacing expert. And he's done a lot of gait analysis studies. So you put people in this lab where you wire them up and you film them, and then you analyze how they walk. That's a gait lab. Unfortunately, you can't do gait analysis on running. What he's found is that at slow walking speeds, patients with a total hip and a resurfacing have a similar gait. They're pretty normal. So these are patients who have an implant on one side and a normal hip on the other. So they have a symmetrical gait at slow speeds. But when you tell them to walk at fast speeds, the total hip patients have a shorter stride length and they unload that hip. That means they drag that leg. So that's just at fast walking speeds. Imagine what happens at running. We can't test that in a gait lab. And finally, I'll leave you an anecdote. Andy Murray had hip resurfacing 2 years ago. He's now in the top 50 in men's singles tennis. That's a brutal sport. 5 sets, 3 or 4 hours of running back and forth. He can manage it in the top 50. He's an aging tennis player. What about Bo Jackson? He was a super athlete who had a bad hip injury in football. He had a total hip replacement. He couldn't play football anymore. He could barely be a designated hitter in baseball. That involves hitting a ball and running the bases. He couldn't even run the bases. He had to quit after a few years. And then he had a revision a few years later. That's a stark example of how a hip resurfacing functions compared to a total hip in very athletic people. The second advantage is greater durability. Currently, my implant survivorship with hip resurfacing at 17 years is 99%. and that's in any age patients. Just to give you a couple of benchmarks, in registries, the average age patient is 70, implant survivorship is 95% at 10 years. I'm getting 99% at 17 years. Furthermore, in total hips, the younger the patient gets, in all the major registries, Sweden, Australia, and England, implant survivorship falls off. At age 50, it's down to 80% at 10 years. Nowhere close to what we can achieve with hip resurfacing. Hip resurfacing is far more durable. Next, hip resurfacing is more stable. I've explained that elsewhere. The hip is mechanically the same size. The dislocation rate with total hips varies greatly. An average number is about 3% within the first few years and up to 5% by 10 years. With resurfacing, my dislocation rate is 0.3%, less than a tenfold reduction in the instability rate. Bone preservation is obvious. The younger you are, the more important that is, because if you have a total hip when you're young and then you have to revise it, it's really difficult to do that next operation. You have to pull that stem out of the femur. So that's an advantage of a resurfacing. The other one is that patients actually have a longer life with hip resurfacing. So that comes out of registry data and lifetime data out of England and out of Australia. If you look at people who are age matched and matched for all other things, even comorbidities and economic indexes and all those things, and you look at a young patient who has a total hip and their chance of dying 10 years later. It's not due to their total hip per se, but people who are age 50, a certain amount of them are going to be dead by 60, according to insurance life tables. If you look at those same rates for hip resurfacing patients, it's 20% lower. Why is that? Why do the same group of patients, if they have a resurfacing, have a 20% lower chance of being dead in 10 years? Probably because they can exercise more. That would be my guess. And finally, the hooker is the problem with wear and corrosion. Now, that's a pretty rare problem nowadays with all kinds of joint implants because they've gotten so good. One of the reasons that total joint surgeons recommend against resurfacing is because they claim that the metal bearing somehow causes more wear debris that's more toxic to the body and causes problems. It is true that you can get excess wear from that bearing and that can cause a failure due to wear debris. But that problem occurs when the cup is malpositioned. We've learned that over the years. I've published several papers, which you can read on my website, that document how that problem has been solved. And since 2009, I've not had a single wear failure. It's because I know how to place the cup right. And if you place the cup right, you don't get wear failures. And that's in over 4,000 straight cases. With total hip replacements, you have a higher rate of wear of the plastic, but you don't get the catastrophic wear if your cup is malpositioned. Instead, you get dislocations, so you get a different problem. You get more instability if the cup is placed too goofy. The other problem you get is corrosion between the ball and the stem. We don't know what causes that, but it's about a 1 to 5% failure rate at 10 years, and it's probably more common in more active people, but we don't really know that, and we don't know how to solve it. It can't be solved by surgical technique, and the implant manufacturers do not know yet how to solve that by implant design. So we had to have a wear failure rate in my resurfacings of 0 in the last 4,000, and we've got a trunnion corrosion failure problem of 1 to 5% in total hip replacement. The problem is greater with total hip replacements, I would say.
All right, so who would be eligible for a hip resurfacing?
At this point, I would say that anybody with a severely arthritic hip who doesn't have extreme bone loss is an excellent candidate for resurfacing. That recommendation has changed over the last almost 25 years that I've been doing this procedure. But there are certain people that still probably would not have a hip resurfacing under my recommendation. And so the first group of people would be people who have severe pain and minor objective X-ray findings of arthritis. So some people come in with a horribly destroyed joint and have hardly any complaints about it. Other people come in with very minor abnormalities that we can detect and have extreme pain. There's something not quite right about their pain sensation mechanism in those patients. And if you do a hip replacement or a hip resurfacing those patients, a high percentage of them will be unsatisfied. They'll still have pain. So the collateral damage of doing a resurfacing or a total hip replacement and the abnormality, the residual abnormality of that is more than the minor findings that you're addressing. So that's the patient group that should not have any kind of joint replacement, in my opinion. But we are sometimes tempted to do them because they are so miserable and we want to help them. But that's a dangerous category of patient to do joint replacement on. And I try to avoid doing it. Some people come with the impression that they have minor x-ray findings, so they're not a candidate for a total hip, but this resurfacing is a more minor procedure, and so somehow they would be a candidate. That's not true. You got to have bad objective findings of arthritis to have a reasonable expectation of liking this after it's done, because I am not making you normal. I'm making you more normal than a total hip, but not totally normal. And there are still people who unfortunately get done and are not happy because they just don't see enough difference between their bad hip and their new artificial hip. Second group of people are those who have extreme bone loss. Now I can do people with up to about half of their femoral head loss. If you're 70 and you have half your femoral head loss, I'm not going to do a resurfacing on you because you're a little higher risk. But if you're 25 and you have half of your femoral head loss, I'm going to do a resurfacing because you're so young, you need that implant for so many more years. So there's a bigger need for the operation the younger the patient gets, and so the amount of risk you'll take on in a patient is going to be greater. And of course, the patient makes that decision, but I counsel them. And the other group of patients that I wouldn't operate on would be those people who believe they are allergic to metals. Now, this is a complicated subject, but basically, internal allergies to metals don't exist, in my opinion. A lot of people believe they have allergies to metals. There's also a lot of stuff swirling around at the internet that you can get blood tests that tell you if you're allergic to this or that metal. And then I've seen recommendations that say you should get this test called the lymphocyte transformation test, and it'll tell you what metals you're allergic to. And then you can present that to your surgeon. He can pick an implant that you're not allergic to. Well, we've tested that hypothesis and we found that's flawed. There's actually no data to suggest that lymphocyte transformation test can predict any problems with hip replacement. So you might say that someone who has a hip replacement or hip resurfacing, and then they're not satisfied and you can't really find a cause, that they're allergic to the metal. That's sometimes what some surgeons loosely say because they don't know. There are people who have unexplained pain. You search for the causes of pain that you know, but then there are people who just aren't happy. It's not perfect. They don't like it. And then sometimes a label of allergy is thrown on there. But there actually is no test that can verify that. And there's considerable evidence in the orthopedic literature that people who have positive skin tests, or now my data on the lymphocyte transformation test, show that there's no correlation with how you react to that test and what the final outcome is. So especially the people with unexplained residual pain, they can't be predicted from a pre-op allergy skin patch test or a pre-op lymphocyte transformation test. So I think it's best just to call those people unexplained pain until we get smarter and learn more and figure out why they actually have pain. But to say that it's due to an allergy is a cop-out, in my opinion. So I don't think there's any such thing as internal allergies. Now, there is certainly a skin sensitivity to metals, and that's chiefly to nickel. And you chiefly see it in common parlance in women who wear jewelry, and they wear jewelry that contains stainless steel. Stainless steel is an alloy of iron and other metals, including nickel, in very small amounts. And the nickel is what people are sensitive to, and they get a rash to stainless steel, either watch band or earring or whatnot. And that's a real thing. And then it can be predicted with a skin patch test. So those exist. You can go to a dermatologist, get a skin patch, and 20% of people have a positive skin patch to nickel. And those are the people that have those reactions to the stainless steel. But if you test people with total hip replacements, 20 of them that are totally happy with their hip replacement have a positive skin patch to nickel. So you see, it doesn't predict an internal problem with metal. It only predicts a skin reactivity. So that's the problem. If you believe you're allergic to metals, I'm going to put in an implant that has cobalt, chrome, nickel, molybdenum, carbon, titanium, aluminum, vanadium. Those are all the metals that are in my implant. There are total hip implants that don't contain the cobalt chrome alloy, so you could have a total hip. But with the resurfacing, all those metals are in there. If you believe you're allergic to one of those, then I can't implant you. I actually don't think anybody's allergic to those, but the patient has to make that final decision. So all patients who have severely arthritic hip, who don't fall into one of those rare categories, are good candidates for resurfacing. And age doesn't matter, sex doesn't matter. I have 99% 17-year implant survivorship in all patient categories.